pembicara internasional, moderator seluruh peserta webinar, serta seluruh peserta yang hadir pada hari ini. Puji syukur kita panjatkan kehadirat Tuhan Yang Maha Esa, karena atas rahmat-Nya kita bisa berkumpul secara virtual dalam acara update terbaru NICU Webinar Internasional 2026 dengan tema Management of Extremely Preterm Infant. Acara ini merupakan bagian dari series ketiga webinar kita, Neonatal Education and Training. Pada kesempatan ini, kita akan bersama-sama memperdalam pengetahuan dan berbagai pengalaman terkait penata laksanaan bayi prematur ekstrem yang saat ini menjadi tantangan besar dalam pelayanan Neonatal Intensive Care Unit atau NICU. Terutama kita akan belajar langsung pengalaman praktek dari NICU Jepang, dari Nagano Hospital Jepang, Children Hospital Jepang, yang dikenal memiliki perkembangan dan kualitas pelayanan neonatal yang sangat.
Selanjutnya,
Saya selaku pembawa acara akan memandu jalannya kegiatan hari ini, ya. Pembacaan tata tertib akan saya bacakan bahwa seluruh peserta diharapkan menonaktifkan mikrofon selama acara berlangsung. Mohon panitia diperhatikan, silakan langsung di-unmute suara-suara yang masuk, ya. Peserta dapat menuliskan pertanyaan fitur Q&A nanti pada saat sesi diskusi. Mohon menggunakan nama lengkap dan institusi masing-masing. Dokumentasi kegiatan akan dilakukan selama webinar berlangsung. Baiklah, mengingatkan kembali untuk peserta yang sudah bergabung dan terdaftar bahwa aturan terbaru dari LMS Kemenkes, pretres wajib dikerjakan dari jam 9 sampai jam 14. Jadi jangan tidak mengerjakan pretes, karena nanti kalau pretes sudah lewat waktunya, akses sudah tidak bisa dibuka dan tidak bisa melanjutkan sampai post-tes. Baik, kita masuk ke sisi diskusi. Mohon tampilkan flyer kita. Hadirin yang kami hormati, peserta webinar, saya perkenalkan dulu moderator kami yang akan memandu sesi ilmiah pada pagi hari ini. Mohon tampilkan CV moderator. Panitia, bisa ditampilkan CV moderator. Baik, berikut adalah CV moderator yang akan memandu sesi ilmiah pada webinar hari ini. Dr. Liri Runjan, spesialis anak, subspesialis neokonsultan, FRACP, dan CCPU. Beliau memang saat ini berkarir di Australia, tapi aslinya dari Indonesia. Ya. Medical doctor di Universitas Indonesia, menamatkan pendidikan tahun 1992, dan Pediatrician Faculty of Medicine University of Indonesia tahun 2004. Beliau juga menamatkan pendidikan sebagai konsultan of neonatologi tahun 2011 dan mengikuti neonatal training in Melbourne, Australia mulai 2006. Jadi mulai 2006 beliau sudah berkarir di Australia, mendapatkan gelar neonatal konsultan atau FRICP dari Australia itu tahun 2022, Certified Clinical Perform Ultrasound CPU Neonatal tahun 2023, Pediatric Advanced Training di Australia dari 2024 sampai dengan saat ini. Saat ini beliau merupakan Pediatric Advanced Trainer Northern Beach Hospital Australia. Baik, Dr. Lili, waktu dan tempat saya persilakan untuk memandu kegiatan sesi diskusi webinar kita kali ini. Silakan, Dokter.
terima kasih kepada Sister Nova. Tolong nggak pakai suara dulu ya. Saya akan kepada semua para peserta, baik para senior saya, kemudian para teman-teman sejawat, dokter juga perawat. Selamat pagi di Indonesia dan siang di Australia. Pagi hari ini saya akan membuka dengan kombinasi bahasa Indonesia dan bahasa Inggris, ya. Okay, so welcome to the third NICU Webinar Series, which is hosted by Neonatal Education and Training. Our topic today is management of extremely preterm infants, and this event is organized to celebrate International Nurses Day in 2026, which we know was on the 12th of May 2026. We have two speakers from Japan. The first one is Dr. Ryo Itoshima. He is a neonatologist from Nagano Children's Hospital. He will present about the best NICU practices in Japan for extremely preterm infants. And the second speaker is Makiko Noda. She's a NICU nurse from Nagano Children's Hospital. She will speak about the role of neonatal nurses, incredible journey of micro premise in Japan. So I just informed that the number of participants registered now are 348 participants. There are 117 pediatrician and medical doctor and pediatric resident 10, nurses 2019, and then midwives 2 of them. So welcome to all of you, and please so enjoy. We will learn together. So I would like to ask to get the CV of the first speaker, Ryo Itoshima. Okay, so Ryo is a neonatologist at Nagano Children's Hospital. So he graduated from Shinshu University in Nagano in 2012, and initially he worked in Nagano Children's Hospital from 2017 to 2020, and after that he went to Finland to do PhD, and he finished in 2025, and from 2025 until now he is working as a neonatologist at Nagano Children's Hospital. So, good morning, Rio. How are you?
I'm good, thank you.
Good. What is the time now in Japan?
It's 16 past 11.
Oh, okay. Good. It's only like 2 hours advance more than Jakarta.
Okay.
Okay, so your time is actually unlimited, Rio. It's like you can share
That's
as long as you want to. Yeah, thank you so much for joining us. Thank you so much for sharing your knowledge to us. So hopefully in the future, Indonesia can progress in terms of the way we manage the extremely preterm infants. As the last around 5 years, we've been managing around at least 26 weeks above, and some in the private hospital like 24 to 26 weeks. Yeah. Okay, Rio, time is yours. Thank you.
Thank you so much, Lily, for this wonderful introduction. And I'd like to share my slide. Can you see the slide now with the title and my name?
Yes, very clear.
Okay, so selamat siang. Saya Rio Itoshima. That's the only Indonesian I can speak. Well, it was some months ago when I received the invitation from Lily that I have this kind of a wonderful opportunity to share my kind of our experience in Japan regarding the extremely preterm infants. And after that, until today, I well try my best to learn Indonesian using Duolingo. You know, we have nowadays application to learn a lot of languages. But well, so far my Indonesian is like this. Saya Rio. it's the only way to introduce myself. But again, thank you so much for this wonderful opportunity. We are very happy and a little bit, well, anxious because I'm not sure if I can tell everything to you today. The time is not limited, as Lily said, but maybe I can finish my presentation in an hour or something. So again, my name is Ryo Itoshima. I'm a Japanese, but I used to live in Finland for 5 years since 2020. So I went to Finland when maybe shortly after the first wave of COVID-19 pandemic. It was, quite a well, challenging moment, not only for us but also for you as well. The traveling to abroad was quite troublesome. And and about the topic. So the top title Lily gave me was this best NICU practices in Japan, but I don't know if this is the best one because nobody knows which is the best. So that's why I inserted this question mark in between. So the first slide I'd like to share is this photo. Can you see the photo now? Thank you. So this is the smallest baby we have received and we cared for in unit so far. And the body weight was only 258 grams. So he was born in our hospital and we tried to save him and he survived and discharged to home from our hospital. And there are a lot of challenges we had to face during his long journey in NICU. So first one about the ventilation. So we had to use HFOV for a long time from day 1 to 69. And after that we extubate. But for 2 months we had to use Nivenaba because he was too tiny. And again, has grown up a little bit, and at 201 day after birth, he was successfully discharged to home. And not only the ventilation, but also there are a lot of things we had to cope with during the admission, the hospitalization. The first challenge came shortly after his birth. So as he was too tiny, we had to use this very thin endotracheal catheter tube. So the size was only 2.0 millimeter. And we of course tried to insert this umbilical line, but umbilical venous line was not possible to be inserted. And we will just give up inserting this venous line through the umbilical line cord, and we tried PICC line, but it was of course quite difficult because its vessel was quite thin. And we usually use SIMV for the first, say, 3 days to 1 week. But for this baby, SIMV was not suitable because his breathing was quite shallow. So we just gave up using SIMV and changed the ventilator to HFOV. And on the third day, we found that umbilical arterial line was placed in the vein. So we on this day, we found that this was the umbilical venous line. And on the day 10, meconium ileus became obvious. So we administered water-soluble contrast to this baby from the stomach and from the rectal. And as PICC line was the only way we can give the water and nutrition or something else. So that's why we had to keep this line. So this, if I remember correctly, this was the first and the last timing for us to avoid lipid administration to prevent PICC occlusion. And as this baby was too tiny, it was quite difficult. The water management was quite difficult. So if we increase the infusion speed by 0.1 millimeter per hour, the water intake of this baby increased 10 milliliter per kilo per day. And at 27 weeks of postmenstrual age, GER, the regurgitation happened. So we inserted transpyloric tube, which is relatively a common practice in Japan. But it was again quite difficult because of this tiny body size. And after that, as he grown up, we are thinking of the timing of extubation. But when to extubate, that was a question because his weight was only 864 grams, which is for our practice, which was quite small, too small to extubate. And after the extubation, we used Nivenaba, but the duration was quite long, so we had to use Nivenaba for 2 months. And we found that there was a poor weight gain, so we added MCT oil, middle chain, what is it? Triglyceride oil. Then on the 201 day, he was discharged home successfully. So on admission, he was such a tiny baby, but he grown up and became 3,300 grams. And this was 3 years old, the birthday. They are celebrating 3 years of birthday, and this is 5 years old. He was dancing. And now he has become, I think, 8 years old. But last year, he became an elementary school student and sing a song, and he is now in the same school as the other student, which was surprising. So this kind of a story was also available from this case report, which was published in 2021. If you're interested in, please look at this article. Yes, so while talking about the relationship between Japan and Finland, what came up to my mind was the similarity of the national flag. So I asked ChatGPT to transform the national flag of Japan to the Indonesian one, and they created this movie. So as you can see, we are sharing the colors of national flags. So red and white are our common colors. But not only these colors in the national flag, but also we have a lot of similarities, like we are island countries. I'm not sure how many islands you have, but I'm sure you have more islands than we have. But anyway, we are also island countries and have a lot of islands. And rice is commonly eaten in both countries. We have this rice and miso soup, and you have nasi goreng. At least I really love it. And we also have a lot of earthquakes. So it was some months ago when we had a big earthquake in Japan, and we are still suffering from the upcoming big one as well. So you may wonder why you have to listen to something from the Japanese guy. So this data is coming from OECD countries comparing the infant mortality rate. So Japan is here, almost the bottom or the top of the world, and on the other hand, Indonesia is still suffering from, I heard, that this infant mortality rate. And this is from the JAMA Pediatrics paper, which was published last year, telling you about the outcomes of preterm infants born 22 and 23 weeks. So among 22 weekers, their survival rate, the probability of the survival to discharge was the highest among Japan. This NRNJ is the Japanese neonatal cohort, the national cohort. And from the same paper, you can also see that Japan is here, and almost all the gestational age between 22 and 23 weeks, Japan is the highest survival rate. And I'd like to talk a little bit about our hospital. So we're now exactly in this hospital. So the name is Nagano Children's Hospital. We are located here. So Japan is such a long country as you have, but we are almost the center of Japan. Then the area is called Nagano Prefecture, which is say 2 to 3 hours drive from Tokyo, the capital city in Japan. And our hospital is almost the center of our national Nagano children and Nagano prefecture. And as we are surrounded by a lot of mountains, maybe 3,000 meters or something, so every day I have to cross over the mountains by bike. And our hospital is here. So the scenery is quite beautiful if the weather is quite good and if it's not winter. In winter, it's quite well troublesome because there are a lot of snows and the road are frozen. So that's why it's quite challenging for me to bike to work. So about our hospital and the NICU, we have 42 beds, including intensive and step-down beds. And we accept about 400 admissions per year, including 30 extremely low birth weight infants. And we have between 10 to 15 doctors and 70 nurses. And we accept 250 emergency transport. And we have about 100 congenital heart disease patients per year. And we have a lot of experience of NIV-NAVA and NAVA ventilation for the last 10 years. And we also nowadays value family-centered care. So on the left bottom, you can see our doctor ambulance. So with which we go to other hospital in our region and resuscitate the baby or doing something. And if necessary, or usually if necessary, but we take the baby back to hospital for admission and the care and treatment. And in the ambulance, you can see a lot of things, like almost everything is in this ambulance, like not only this incubator and ventilator, but also everything. And we also accept doctor helicopter transport sometimes, maybe 5 to 10 times per year or less than that. And this is a picture of our intensive beds. And this is the step-down area. So you now may wonder why Nagano? Well, why you have to listen to the guy from Nagano. So this is the article, the evidence from our hospital, which compares the outcomes between 22 and 23 weekers. You can see the survival rate among them was 81% among 22 weekers and 93% among 23 weekers. And talking about tiny baby, I compare the outcomes, well, including survival rate of those who were born weighing below 500 grams and found that it was 100%. So, of course, it was a big challenge for us and it was a miracle. But at the same time, this the survival of this tiny baby whose birth weight was only 250 grams was not only the miracle, but also kind of a basis of our best care. So, well, today's topic I'd like to share with you are these topics. So first, we are sharing the respiratory management, then IVH and prevention, sepsis infection control, and the last one is family-centered care. So the first topic is the respiratory management. So this is a statistics, and unfortunately, the BPD rate at 36 weeks of post-menstrual age is higher in Nagano than in the Japanese standard. But I think the definition of these two are quite different between Nagano and in Japan. So that's why this difference might affect these big differences. But anyway, BPD is a quite big issue we had to cope with still, not only in our hospital, but also in many places in Japan. So in this slide, I am briefly sharing what is our kind of a idea how to prevent BPD, or what is the the tips of respiratory management. So in the first half of this graph, you can see that SpO2 level is quite stable. But on the second half, there are some drops in the SpO2 level. So I'd like to, well, we try our best to minimize SpO2 variation, not only to prevent BPD, but also to prevent the brain injury. So the first half is quite a good, stable one. And we'd like to reduce the time when the baby's SpO2 level drops like this, the second half. So to achieve this, well, of course, the nursing care will be presented by Makiko later, but I'm briefly sharing you our kind of ideas, how to cope with this small baby when it comes to, regarding the respiratory management. So as I told you, first we use SIMV after intubation and surfactant administration. Then we try to change the ventilatory mode to NABA as soon as possible, which is not easy if the baby is quite tiny. Then we sometimes have to use HFOV, but try to minimize to use HFOV as a rescue therapy. And also we try not to use HFOV for the first 3 days to prevent IVH. And after extubation, we usually use NIV-NABA, then high flow, and if it's needed, we sometimes use oxygen, but nowadays we just remove the high flow from the baby, and that's it. And for the first 3 days, we usually use the fentanyl for the sedation, as a sedation. And talking about systemic steroid, our protocol is like this, that the first line is hydrocortisone, starting with 3 milligram per kilo per day, and just weigh it and use the hydrocortisone for 1 week or something. And if it's not effective, we try the second line or second dose, or if it's not effective, we use the second line, which is dexamethasone. And we also administer inhaled steroid, fluticasone, to prevent BPD until the extubation. And while talking about apnea, I'm sure you also use this, but we use caffeine. We usually introduce caffeine, beginning at some days after birth until, say, 34 or 5 weeks of postmenstrual age. And the dosage is about 5 to 10 milligram per kilo per day. And we sometimes have to use doxapram. I heard that you never have it in Indonesia, unfortunately, but we try to kind of activate the baby's respiration, stimulate the baby's respiration if the apnea is quite severe. So this is a short summary. So to prevent BPD and the brain injury, we try to minimize SpO2 variation, which is quite important. And I'm sure not only our side, but also the nursing side have to pay attention to this or work hard to achieve this goal. So the next topic is IVH and its prevention, which is of course super important. So among 22 and 23 weekers, the incidence of IVH grade 3 or 4, the severe one, was like this. So among 22 weekers, it is 13%, and among 23 weekers, it's 15%. It's still high, but compared to the Japanese standard, it's a little bit lower. So talking about the management of IVH prevention, I think these 3 points are very important. The first one is prenatal management. And what I think we believe is important, first of all, is to take the mother to our hospital, not the baby. So the maternal transfer or referral is quite important. And also the prenatal steroid is also important, which has a lot of evidence on it. And the next one is the resuscitation. Let's see. The first one is the neonatal resuscitation kind of a project, national project in Japan. We call it NCPR, Neonatal Cardiopulmonary Resuscitation. So like this, I heard that Indonesian also has the similar system, which is quite nice. But in Japan, we have this kind of a system which imitated the American one in 2007, and which targets for all the healthcare staff working with babies. And we adopted licensing system, and we had to renew it every 3 years. And the next topic is resuscitation in an incubator to minimize infant transfer. So if we have to take the baby from this place to that place, this movement is quite harmful for the baby, which might be the risk of IVH. So that's why we try to minimize the baby's transfer. So I'm showing you this movie. Sorry, maybe it's better for you to listen to what is happening. So let me stop the sharing and let me share the slide again. Lily, can you see my slide?
Yes, I can.
Thank you. So now let's move on to this movie. It's a short clip, say 1 minute. So please look at this, how we resuscitate the baby in an incubator. So now baby is arriving from the mother's place to this incubator. So the nurse is taking the baby to the incubator and put the baby in. And we are now wiping the baby's skin, try to do the suctioning in the mouth, and remove the wet towel and start the ventilation. And the doctor is now doing the intubation, and the tube, I think, is now 2.5 millimeter. And he's checking the CO2 level or if the intubation was succeed. And they're changing the baby's place, the position, and moving the baby to the NICU now. So this is how we do everything in an incubator. Unfortunately, I can't find a movie in which I can show you how we insert the umbilical line to the baby. But we do everything, including the umbilical line insertion in an incubator, which I think is possible. And the last topic I'd like to share is the umbilical cord milking. I don't know your practice in Indonesia, but in Japan, this cord milking is still a common practice, not the delayed cord clamping. So I'm also sharing how we gently do the umbilical cord milking after breathing is established. So now the nursing is doing the milking like this and clip the cord. So what we believe is important is to do the milking as gently as possible and do it after the breathing is established. Otherwise, the IVH incidence might increase. Yes, well, and talking about this resuscitation now, it's not the main topic, but I'd like to share the floor map of our hospital. So our NICU is on the right side of this map, and on the left side you can see the maternity unit and the neonatal unit. So in this maternity unit and neonatal unit, we care for not only the mother before delivery, but also the mothers after delivery, and also the newborns who are healthy or almost healthy and no need for the intensive care. So we are on the same level, and in between there are two bed delivery rooms and one C-section room. And just beside these three rooms, we have resuscitation room. So it's quite easy for us to access to NICU, or we also have step down area, which is called GCU in Japan, quite easily. Yes, and talking about delivery room, one of the delivery rooms looks like this. So it's quite big, and if the baby is healthy, we resuscitate the baby in the open incubator on the left side of this picture photo. And this is a C-section room. So we have the operational room on the second floor, and we are on the same third floor. So anesthesiologist, and the nurses from the operation room are coming to this C-section room when is needed, which is a little bit troublesome for them, but I think it's good for the baby not to be transferred by elevator. And this is the resuscitation room, so we always keep the incubator warm, like the one on the right side, and on the left side you can also see the open incubator warmer, which is also ready for those who are born maybe 30 weeks or above. And the room temperature of this area, not only in the incubator, well, in the incubator, the temperature is much higher. But anyway, the room temperature is kept to 30 degrees Celsius, which is quite well troublesome for us. It's sometimes like sauna, but we try our best to minimize the baby's hypothermia. So that's why we should keep this high temperature. And nowadays, no one is complaining about this high temperature, but I'm sure at the beginning, it was a little bit, well, challenging for them to say that we need to keep the temperature high like this. Because, you know, they're obstetricians, they're anesthesiologists, they're nurses, and they are usually working in the very cold place in the operation room. But in this C-section room, the temperature is kept 30 degrees. And when extremely low birth weight infant is born, at least 2 doctors and 1 nurse, NICU nurse, is coming to resuscitate a baby. And it is a NICU nurse who take the baby from the delivery room or from the C-section room to the resuscitation room. So they are holding the baby and not running, but walk quickly to the resuscitation room. It's just side by side, so it's quite easy for the nurse to take the baby to the resuscitation room. So, I think I already showed you how we deliver the baby to the NICU, but just in case. So we are using the same incubator to the NICU after the resuscitation. And we are continuing the bag and mask ventilation until the baby reaches NICU. And we continue using the same incubator. We never change the incubator. That, I think, is super important to prevent IVH. Yes, and talking about resuscitation, this is, well, not the main part, but we use this surfactant, which is called surfactant, which is the powder. So we have to we'll use the normal saline or something to make it to the water. And the last topic to prevent IVH, severe IVH, is the NICU management. So again, I show you this chart. On the first half, you can see the heart rate is quite stable, which is nice. But on the second half, you can see the heart rate is sometimes dropping a little bit, which must be harmful for the baby's brain. So the idea is to minimize the variation of the heart rate and blood pressure as well. So to achieve this, there are some kind of tips we have. So the first one is a minimal handling. So we never measure weight for the first 10 days. And we nowadays never move the baby. So in this photo, you can see the baby's head is on the right side, but nowadays we never will put the baby like this. So it's usually on the center part of the trunk and no trunk position change at least. And we never put ECG monitor, which is harmful for the baby's skin and which is not necessary for us. So only SpO2 monitor is put to the baby and it's on the left leg for this baby. And minimal suctioning is also important because each suctioning is harmful for the baby. I think Makiko will let you know how they're handling this suctioning and what is their tips to minimize the frequency of the suctioning. And we placed the urinary catheter, which is also important to minimize the movement of the baby. So we never there is no need for us to change the baby's diaper every 3 hours. And talking about prophylactic indomethacin, so we still have indomethacin in our hospital. And we use prophylactic indomethacin for those who are born below 26 weeks. And the dosage is 0.1 milligram per kilo for 3 days. But I heard that you never use indomethacin in Indonesia, unfortunately. And while talking about the treatment of PDA, the first line in our hospital is ibuprofen, which is quite common nowadays in Japan. And the second line, I think, is indomethacin. But nowadays, I think also acetaminophen is becoming more and more common as a treatment of PDA. And while talking about sedation, to stabilize the circulatory dynamics, we introduce sedation, and we use fentanyl, and the dosage is about 1 to 2 microgram per kilo per hour for the first 72 hours. But in Japan, sometimes, some NICUs use morphine or phenobarbital as a sedative medication. And we usually add 2 more days when we find IVH. And talking about blood pressure management, we of course place arterial line, and the target mean blood pressure is almost the same number of gestational week. And we try not to hurry to correct low blood pressure, because if the blood pressure rises quickly, then it may harm the brain circulation, and which might lead to IVH. And talking about the water intake, the initial infusion volume is about around 60 to 80 milliliter per kilo per day, which I think compared to other NICUs in the world, I think this number is quite low. But I think we usually keep the humidity in the incubator so high, like 25 or almost 100% for the first some days. So that is one of the reasons why we don't have to give a lot of water to the baby during the first some days. And as I told you, we never do the body weight measurement during the first 10 days. So during that period, we can't see any change in the baby's weight. But to replace that, there are a lot of things, important factors we can see, like fluid balance, blood pressure, heart rate, echocardiography. We usually, neonatologists usually do the echocardiography every, 2 or 3 times per day for those who are born 22 and 23 weeks to check left ventricle size and contraction, IVC, the size, and the PDA, and if the PDA is symptomatic or not. And we also see the brain ultrasound. So these are kind of management in your hospital. And talking about this water management or something, I would like to share some small tips. So I think if you handle a very tiny baby in an incubator with low humidity or even without any incubator, then you might have this high sodium level problem. Of course, we do have this problem if the water intake is less than necessary. So we just increase the free water intake using glucose if we see the high sodium level, and if we think that water loss is the cause of this high sodium level. And of course, water loss can be detected not only by serum sodium level, but also fluid balance, ultrasound. So we see everything. And about metabolic acidosis in an acute phase, we sometimes see the baby is having this metabolic acidosis, and we usually administer sodium bicarbonate if base excess is below -5. And we usually not add bicarbonate to this TPN. So it is only added when it's necessary. And this is a small tip, but if you're interested in, please look at this article from 2015, which is written our colleagues in Japan. So the idea is to measure internal cerebral vein fluctuation. So you see on the left side, there is the Doppler ultrasound, which shows the artery on the frontal side of the brain. But below the chamber, you can see the ICV, so the internal cerebral vein. And if you measure it with the Doppler ultrasound, you can see the flow, the waveform. If the waveform is fluctuated like C or D, this may indicate that the venous status, which might lead to IVH. But if it's quite stable, like in A or B, we are happy because the venous status is not happening for this baby. I think nowadays it's quite popular among the Japanese neonatologists to measure the fluctuation of internal cerebral vein. So if you're interested in, please just try it. So this is a summary, which is a big summary, so you don't just forget this. But there are 3 topics we think is important to prevent IVH: the prenatal management and resuscitation, and even after NICU admission. And the main idea is to minimize heart rate and blood pressure variation. And the 3rd topic is the sepsis and infection control. So it is unfortunate that the culture problem sepsisemia or bacteremia, the rate of this condition is higher in Nagano than in the Japanese cohort. But while talking about early onset sepsis, we seldom have this kind of a patient who has early onset sepsis among 22 and 23 weeks. So the important management to treat and control infection is, first of all, to these 2 topics are important. The first one is empirical antibiotic use and the NICU management. And talking about empirical antibiotic use, we just start antibiotics as soon as possible when it is needed. So this speed is quite important, I think. And start with narrow spectrum antibiotics, if possible, if the baby's condition is not very bad. So this is our first line regimen. So the ampicillin and gentamicin in our hospital, but it depends. Sometimes it's ampicillin and cefotaxime. And we do collect blood culture before antibiotic use. And in Japan, it's usually the dosage is only 0.5 milliliter. And we try to minimize the duration of the antibiotic use. So it's usually 48 hours until, unless the blood culture is proven to be positive. And talking about wide spectrum antibiotics. So it's only used, they are only used when is needed, like meropenem, vancomycin. So they are only used when it is needed. It's not usually used, especially shortly after delivery. And the NICU management. So there are a lot of NICU management I'd like to share with you regarding the infection control. And talking about these standard precautions and skincare, I think Makiko is the best one to talk about these topics. So let's skip this. And we're talking about prophylactic immunoglobulin, intravenous immunoglobulin. We do give this prophylactic immunoglobulin for those who are born below 25 weeks. And the dosage is 250 milligram per kilo. And prophylactic antifungal medicine is also important, I think. And we routinely administer this antifungal medicine for those who are born below 26 weeks. And the first one is intravenous phosphorconazole while central line is placed. And the second one is the enteral fluconazole for the first 30 days. And what is also important for the baby is to establish normal flora. So what kind of bacteria they will receive in the gut and on the skin and in the nasal area is important. So we encourage parents to touch the baby, and we administer bifidobacterium for the first 3 days, 30 days. And we sometimes place a cotton swab with breast milk in the baby's mouth like this. So sorry, the photo is a little bit small, but you can see there is a cotton swab with a stick in the baby's mouth, so that baby can kind of feel the baby, the mother's breast milk, and also establish the good flora in the mouth. And we also put gauze or towel that has been in contact with the parent's skin on the baby. So we encourage parents to have towel or anything on their skin. So for example, the father put the towel in their chest and wait for the 30 minutes, and they remove it and take it to the baby's place, and they put the towel just next to the baby so that they can feel the parents, and also they can receive a lot of good bacteria from the parents. And the last topic is family-centered care. So it is very much unfortunate that the design of our unit is like this. So we are open bay setting, and we just have one private room, but which is just one room, and which is usually used shortly before discharge to home. And as Lily told you, that I went to Finland in 2020, and before that, I was wondering, well, the parents' responsibility and its change was like this, and I really wanted to change this. So the curve was like this. So on the y-axis, you can see the parent's responsibility from 0 to 100%. And on the x-axis, you can see the time. So the beginning is a NICU admission and the NICU discharge on the right side. You can see how the parent's responsibility changes typically in our hospital before 2020. So during the first phase, parents are just bystanders. So they're just sitting beside the baby's incubator and looking at the care of the nurses. And the care by parents actively starts when discharge approaches. And parents, in this situation, parents are mostly taught about caretaking of their baby. So they're not learning by themselves. And parents are intensively prepared for the baby's discharge because the discharge is getting closer. Or in this phase, the baby is already ready for discharge, but we have to wait for the baby to be discharged because parents are not ready for discharge. And parents, sometimes don't want to discharge their baby because they're not ready. They're not confident in baby's care. So that's why even after discharge home, parents feel anxious and call or visit the hospital after discharge. So before I went to Finland, we quite commonly received a phone call from the parents whose baby is already discharged to home, asking about their baby. For example, oh, my baby is doing like this or vomited a little bit once, and what should we do or something, which is quite common. Like the small vomiting quite commonly happens to any baby, but this kind of parents don't know how to cope with that, which should be learned in NICU. So this red curve is kind of an ideal curve. So the parent's responsibility should be promoted even shortly after admission. And when the baby become ready for discharge, the parents are ready, be confident in baby's care, and happy to be discharged their baby and take the baby back home. But anyway, in 2020, during the COVID period, I went to Finland, and this is my boss. So my mentor or my supervisor as a PhD student, and asked her if you have the similar problem in Finland. I'm not sure if you have the similar problem in Indonesia, and if you don't have, then just forget everything in this slide. But she answered that most Finnish parents want to take their baby back home as soon as possible, which was quite surprising for me. Because in Japan, the situation was like this, that many parents are anxious and don't want to take their baby back home, even when the baby is ready for discharge. And I was wondering what makes this big difference. And this is a picture of the new unit in Finland. So I was working here. The NICU moved to this new unit in 2023, I think. So you can see this is very beautiful. This is a corridor of the NICU, and you can see a lot of doors for each private NICU room. So all the NICU rooms or beds are private room. And in the room, you can see, on the left side of this room, they will put a baby or two babies. If the baby is twins or if the babies are triplets, they put three babies in this room. But anyway, and over there, you can see two adult beds, which can accommodate two parents all at the same time. And in the same area, each parents can use the private toilet and shower. And you can see there are a lot of things like care table and their fridge or something. So everything is in this private room. And each room accommodate the same thing. So I was wondering if if I were parents, this room looks quite comfortable compared to our NICU. So that's why I don't want to be back to home with the baby because their area is quite comfortable. But when I attended the morning round, this was also surprising. So this photo is taken during the morning round. So in Japan, the morning round is like this. The babies are lying and we are getting together to the baby and standing. Maybe 5 to 10 doctors are standing beside the baby and talking about the baby at the same time. So if I were parents, I don't want to be there during the morning round. But in Finland, the situation was quite different. So you see on the left side, there are two parents sitting on the kangaroo chair, and the father is still, already holding the baby. And on the right side, you can see doctor, the physician, and one resident, and there are standing nurse, NICU nurse, who is in charge of this family. And the striped lady is the psychologist. No, psychologist, that's right. So the morning round is like this. And what the doctor asks the parents first, or talk to the parents first, is how your baby was doing during the evening, during the day. So usually, if the parents were there, we just ignore parents. Or we just tell the parents that these are things we have decided and this is the plan for today. But in this case in Finland, they just ask parents about the baby's condition during the night, which was super surprising for me. And every time they make the decision in the round, they also ask the parents' opinion and they decide everything together with parents. So this was quite different from our practice, at least in Japan. So I realized that communication is the most important thing, not just the design and the beautiful NICU room, but also this communication is quite important for the parents to be ready for discharge. And I learned that this close collaboration with parents training, this is a training program. This is on the basis of this good communication in Finland. So let me briefly introduce this training program. So this program developed in Finland, and this is an educational program for healthcare staff in NICUs to learn better communication to promote family-centered care in the unit and treat and care for newborns together with parents in NICUs. And the learning system as a NICU is like this, that we first train the mentors. So mentor is kind of a responsible persons from a unit. And the mentors, will train the other staff members in the unit. So as a unit, the training usually continues for the 1.5 to 2 years in total. And the training contents consists of these 4 phases, training phases, and each phase has their own topic. And the learning process is like this, that the mentee, those who receive the training first learn the theory by e-learning. Then they do the bedside training with the baby and the parents. And after that, we do this reflection. So this reflection session is quite important, we believe, because in the reflection, we kind of digest what we have experienced in the bedside training and learn something from that and think about how to improve our daily practice. So I think the details of our family-centered care will also be taught to you from Nakiko, but these are the four important components which we want to achieve through family-centered care. The first one is promotion of parent-infant bonding. Of course, this is quite important. And empowering parents to take active roles in the care and everything. And enhancing parental confidence. And information sharing and shared decision making. These are also important factors. Yes, so this is almost the end of my presentation, but Lily told me that you're also interested in feeding practice in my presentation, which I'm so sorry, which has already been removed. So I briefly let you know the feeding practice in our hospital. So first of all, when and how to start the feeding for a baby. If the baby was born 22 or 23 or 24 weeks of gestational age, we usually start the enteral feeding on day 0 or 1 with 0.5 milliliter breast milk per day. And we sometimes or usually or quite commonly see the abdominal distension, which is quite common. So how to cope with this? So we first start glycerin enema and rectal decompression. And if the distension continues, we reduce or stop the enteral feeding to avoid neck, of course. And if the distension continues still, we continuously decompress the stomach by tube. And so this continuous gastric decompression is initiated. So if meconium illus is suspected, for example, like the one who I presented in the first half of this presentation, water-soluble contrast is administered to the stomach or from the rectal, through the rectal. And we fortunately have this donor milk system in Japan. So we start enteral feeding with breast milk or donor milk for very low birth weight infant. And donor milk is used until 34 weeks of postmenstrual age along with breast milk. Of course, well, it is important at the same time to encourage mothers to produce breast milk. And about formula, only for those who is matured enough or refuse to use donor milk without any breast milk, we use formula, but we try to avoid formula to avoid neck, of course. And about the fortifier, breast milk fortifier, we start fortifier when enteral feeding exceed 50 milliliter per kilo per day until about 2000 grams. And if the baby need a feeding tube at home, well, actually in Finland, this was quite common. Well, taking the tube feeding to home and the feeding tube, using the feeding tube at home, because the babies, preterm babies in Finland usually be discharged to home when they're, say, 6 weeks of postmenstrual age. But in Japan, or at least in our hospital, we usually keep the baby until due date. So not all the baby need a tube feeding when the baby is discharged to home. So it is not a common practice, but only for those who may need tube feeding for a long time. And this, sorry, it's written only in Japanese, but in the document, this is a document for parents to record their experience about tube feeding. So if they experience the preparation of the tube feeding, and if they can see the baby's behavior and the condition, if the baby is good for tube feeding, and the length of this tube, every time they insert the formula or breast milk, they have to check the length of the tube but if they can check it or something. So like this way, every procedure they have to experience should be checked by parents. So this is my last slide. Thank you for your attention. So what we value the most in extremely low birth weight infant management is the BPD prevention, IVH prevention, sepsis prevention, and family-centered care. Of course, the detailed nursing care will be presented later by Makiko. And here's a manual showing Japanese standard care for very preterm infants. It used to be available for free, but nowadays it's unfortunately not available for free. So you can see this, you can buy the manual from this link or QR code, but I have the free one. So if you're interested in very much and have no money, please just contact me through this email so that I can contact you with the manual. And talking about the close collaboration with parents, we have the website in Japan, which is also available in English. And we have the YouTube introduction movie. So if you're interested in family-centered care in this training, please just watch the YouTube movie. So again, thank you so much for your attention and listening to my presentation. I'm so sorry that my English is not good, so I hope you got everything from my presentation. Terima kasih.
Thank you, Rio. Your presentation is very great. And your English is perfect.
Nice to hear that.
Yeah.
Thank you.
Okay, so thank you so much. So when you shared your first case, actually I was in Nagano Hospital at that time in 2018, October 2018. That baby was just around 3 days old. And then that was actually the first time I met you at that time.
That's
So
true.
the nicest doctor over there who I can easily spoke in English. Yeah. Okay. So Rio, I need to give summary in our language first, and after that,
Yes.
I can open some questions. So in the meantime, if you can read in the chat, like in the chat box, and then probably you prepare your answer from there.
Okay, thank you. I'm
Thank you.
waiting.
Ya. Jadi para teman-teman sejawat sekalian, saya akan summary-kan terutama pada para perawat ya. Jadi tujuan utama dari perawatan bayi ekstrim prematur ini adalah tidak hanya untuk meningkatkan angka survival, tapi tentunya kita mau long term neurodevelopmental outcome yang intact ya, jadi tanpa kecacatan. Nah, seideal mungkin kalau tadi memperhatikan dari awal sebetulnya adalah kerjasama yang baik antara tim sejawat dari kebidanan dan neonatal. Jadi kapan waktu terbaik untuk melahirkan bayi, kemudian dia misalnya pakai antenatal steroid dan sebagainya ya. Nah, tahap-tahap yang perlu diperhatikan adalah bagaimana nomor satu nih saya summary-kan delivery management sangat penting. Kemudian fase akut dan stabilisasi di NICU. Yang ketiga adalah feeding dan growing serta persiapan untuk pulang. Nah, untuk delivery management tadi kita perhatikan suhu aja dia buat 30 derajat. Nah, tentunya ini agak berbeda dengan pengalaman di Indonesia. Kalau kita mau minta suhu 22 derajat aja udah berantem dulu gitu ya. Jadi mungkin nanti ke depannya kita akan melakukan pendekatan ya ke arah anestesi, kemudian ke dokter kebidanan ya supaya ini bisa menolong pada saat resusitasi untuk namanya thermal managementnya. Kemudian tim yang hadir tentunya adalah yang mempunyai kompetensi paling tinggi, terutama ini karena semua yang diceritakan itu adalah manajemen ekstrim preterm yang 22-23 minggu. Ya, saya cuma share sedikit di Australia saja itu hanya satu center yang memanage 22-23 minggu, cuman sisanya enggak, sisanya tuh 23-24 minggu. Jadi artinya ini satu kompetensi yang sulit. Terus tadi tim yang hadir, setup ruangan dan alat-alatnya, dan bagaimana kita mentransport bayi ke NICU. Intinya jangan pindah-pindah waktu ngangkat bolak-balik kepalanya goyang-goyang itu bisa risiko dari IVH. Kemudian manajemen di NICU itu yang paling penting adalah meminimalisasi fluktuasi heart rate, blood pressure, kemudian oksigen. Ya, jadi sangat penting tadi pencegahan IVH, kemudian termasuk manajemen yang gentle mengenai cairan, inotropik, bagaimana screening PDA, itu semuanya sangat penting. Kemudian ventilation manajemennya juga, misalnya harus tadi lung protective ventilation strategy, ya, terus infection control. Nah, yang dua hal ini yang mungkin belum terlalu diperhatikan ya di Indonesia adalah ini GERD management, yaitu pemasangan si tadi transparent tube. Jadi sering di Indonesia kalau feeding intolerance dipuasakan gitu. Padahal makin dipuasakan makin risiko neck makin tinggi, kemudian mucosal atrofi dan lain sebagainya gitu. Risiko infeksi juga makin tinggi. Nah, terus hal yang kedua adalah manajemen konstipasi. Dia secara aktif memberikan enema. Itu si pemberian enema ini ditujukan adalah mencegah distensi abdomen yang akan mempengaruhi tadi fluktuasi oksigen sehingga dokternya cenderung turunkan ininya, presernya, oksigennya, jadi malah membahayakan bayi. Jadi dengan adanya si ini constipation dikasih enema ini membantu untuk menurunkan kejadian dari feeding intolerance. Nah, sekarang apa yang kita bisa pelajarin di Indonesia untuk diterapkan untuk kedepannya? Nomor satu, menurut saya ya, ini yang saya lihat juga berbedanya dengan Australia. Kenapa dia di Australia itu survivalnya lebih rendah daripada di Jepang. Nomor satu adalah yang mungkin kita harus teliti. Memang belum ada penelitiannya adalah sedasi untuk ekstrem preterm infants. Ya, dia memberikan fentanyl di 3 hari pertama. Itu saya belum lihat dikerjakan di Australia. Jadi bisa saja bayinya fase akut, bayinya mungkin nggak nyaman, kesakitan, dia gerak-gerak, terus manipulasi ya. Itu menyebabkan risiko terjadinya IVH di beberapa hari pertama kehidupan. Itu satu. Kedua adalah praktek, terserah kita mau mengakomodir yang mana, delayed cord clamping kah, atau kita mau umbilical cord milking kah. Nah, itu mungkin nanti didiskusikan untuk kedepannya, karena ini sangat penting pada bayi ekstrem preterm infants untuk mencegah hipotensi. Ya, terus tadi mengenai bowel washout, transpyloric tube, kemudian ke depannya kita mungkin belajar NAFA. NAFA ini sangat bagus untuk bayi-bayi ekstrem preterm, ya bayinya sangat nyaman ya, mencegah. Jadi ininya walaupun belum terbukti secara penelitian, kalau menurut saya karena orang belum familiar dengan NAFA ini. Kemudian tadi pemilihan penggunaan kafein, karena di Indonesia masih pakai aminofilin. Jadi nanti ke depannya kafein ini mempunyai efek diuretik dan dia lebih safe. Sementara aminofilin ini efek toksisitasnya jadi narrow, dia ini sekali therapeutic level sama toksisitasnya itu ini banget, batasnya sempit banget gitu. Nah, tadi nanti mungkin akan dibahas oleh Makiko adalah skincare nanti. Nah, kemudian probiotics ini ke depannya menurut saya perlu diterapkan. Dan yang terberat menurut saya tadi adalah breast milk. Di Indonesia tuh angka breast milknya untuk bayi-bayi kecil ini kecil sekali ya. Jadi menurut saya segitu. Nanti mungkin dalam pertanyaan kita akan tambahkan lagi ya. Okay, so I have summarized Rio. So I will open the discussion now before we move on to the next topic by Makiko. So I think the first question by Nurse Iin. So the first one I think she misunderstood. I already clarified with her. So I think the second question was almost similar with the question which is asked by the doctor about the role of the steroid. So if first question actually, how early do you use the steroid? And then do you observe an increased incidence of steroid complications? And then, yeah, that's it for the first
Okay.
question. If you can
Thank you.
answer that question first.
Thank you so much for this wonderful question. I think it's quite important for us to think about when to start the hydrocortisone. I think, well, there are two reasons why we have to use steroid. The first one is to stabilize the circulation, and the second one is to kind of prevent BPD. So to stabilize the circulation, we sometimes use the hydrocortisone, and the dosage is just 0.5 or 1 milliliter per kilo, and which usually is administered for the first 24 hours or something. But we also use catecholamine or something to increase the blood pressure. So it is, of course, not necessary. And talking about the steroid to prevent BPD, I think we try our best not to use it for the first, say, 3 days or 1 week, because it's too early for the baby to receive the steroid. And of course, the complication is quite severe if it happens, and we try our best not to use the steroid together with indomethacin or ibuprofen, because both have this complication in the gut. And usually during the first 1 week or something, we commonly use the prophylactic indomethacin or treatment using ibuprofen. So that's another reason why we want to avoid using hydrocortisone for the first 1 week or something.
Yeah.
Am I answering the question right?
Yeah. So the question is asked by Dr. Ahmad. Currently, he is in Australia. So in Australia, we see, like we witnessed, if let's say the baby required indomethacin, and also at the same time we introduce steroid for like many reasons, and then there is a we don't see many, but at least I myself I saw at least 3 cases, the spontaneous intestinal perforation. Yeah. That's why I mean, like, yeah, obviously, like in Australia, we try to avoid not using the steroid in the first week, if possible, to delay until the second week.
I agree.
Yeah, and then it's a question from Dr. Ashari. Do you regularly check cortisol level for tiny babies, especially when they have like low blood pressure or difficult management of hypotension?
Well, we never measure it. That's the
Okay.
question. But
Yeah.
but of course, sometimes we see the baby has a low blood pressure or something, and we suspect that this baby might have the low cortisol level, but we never measure it.
In our experience in Australia, we don't measure cortisol level in tiny babies, but in term babies, yes. If you think why the effects not as our expectation, then we check the cortisol level. Yeah. And then regarding the size, this is, I know that you use different, you don't use Vigon. So one question from Dr. Ahmad, like if, let's say you have to insert PICC line in 250 grams, that baby, which PICC line that actually you use? And I know because like, yeah, I know we use Vigon. Vigon Premicat is 1 French. 28 gauge, and then whether you use the same 28 gauge or
I think well, Makiko told me that it's you were talking about PICC line.
yes,
It's
PICC line.
27 French.
Oh, you
27
have
French.
smaller. Okay, you have smaller. Yeah, because like we use Figon. Australia also only the smallest one is Premicat 28 grades. Yeah.
Mhm.
And then do you have double lumen for that
Yes, the
in
pick. Or
27 you have so like in Australia 20 said one France 28 gates there is no double lumen
well, we do have it.
in which like how small for double lumen.
27
Oh,
French.
so it's actually technically 0.5 friends because
Mm.
you have like 2.5 friends inside the 27 grades.
Mm,
Yeah.
that's right.
Okay.
That's right.
Anyway, because there is a question if you need to give bicarb, like how you give it in very small baby. So obviously you
Mm.
need to have double lumen,
Two
or
lumen. Yeah,
you
exactly.
put
Exactly.
two PIC lines. Yeah.
Mm. Yes,
Uh,
I think there was a question about the speed of this correction using bicarbonate. I think
yeah.
we if the baby is quite small, then we take 2 hours to correct
Mm, yeah.
the
Yeah.
yes.
And do
As
you
the
use, I think half or full correction depends on how you predict that, how severe
sure.
is the case.
Yes,
I think.
but first we try half correction, and if it's not effective, we try full correction.
Okay. And then for echo, how early whether you do it? Obviously, I know you must do it like whenever the baby arrive in NICU in the first hours of life. And then when will be the next one? Whether 6 hours later or 12 hours in the 22 to 23 weeker?
We commonly do the echocardiography like this, that we do it every, say, 8 hours or something.
Mm.
So the next one should be 8 hours if after,
Later. Yeah.
yes.
Okay. Do
But
you
if the baby's condition is quite severe, like if we suspect the baby has a severe PPHN or something, then if we really want to evaluate it, and we try our best to minimize the time and try the echocardiography a little bit sooner than that.
Mhm.
But we try our best not to do it frequently.
Yeah, try to not to disturb the baby. Yeah.
Exactly.
Do you use a PDA scoring system?
Well, we know that there's a PDA scoring system, of course, in Japan as well, but we usually not use it. So we measure the size of the PDA and flow, and oh well, for example, the flow of the left PDA.
You
If
mean
the
the PDA
diastolic
pattern?
flow of the
Yeah.
left PDA is quite severe, then we just start the treatment. So scoring system is unfortunately not commonly used in our hospital.
Okay. And then what happen if you find out there is severe IVH with the ventricular dilatation? Do
Uh,
you regularly do therapeutic LP?
no, because we don't want to move the baby.
Mm.
So if there is a dilation, the dilation is getting worse, then we just ask the neurosurgery surgeon to put
To put
what is the name of this on my ear.
like yeah, or
Yes,
like before like reservoir before the
exactly.
what is the name again? Yeah, okay, I understand what
BP
you mean.
shunt. Yes.
And yeah, vision, correct. And there is a question, I add my own question. What happen if you see the type of C or D of the fluctuation waveform in the
Mm.
brain? What would you do in that moment if you said, oh, there is a prediction of the baby developing IVH? Will you change something in your management based on your experience?
That's a very good question. And we also have the same question, but the paper doesn't tell us how to cope with that. And there's no kind of evidence. Well, what is the best choice if the baby's fluctuation is like C or D? So, well, the answer is I don't know. But there's a kind of a, well, first thing is we have to check the circulation using ultrasound or something and see if for example, the contraction of the heart is quite stable, or if it's not so, then we must do something. But we don't have any kind of a protocol or something how to cope with this situation.
Okay. So next question, I think I already asked to you, but I would like you to answer this question. Do you regularly check CMV level in like in the baby and also in mother's own milk?
Well, talking about the baby, we not we don't routinely check it. But if the baby has some symptoms like the brain dilation or whatever, we just check it. But for the mothers, we usually don't measure it, or the breast milk as well. Because, well, to prevent CMV
Breast.
infection through the breast milk, we usually freeze the breast milk.
Yeah.
1 week after, yes, starting 1 week after the delivery until 34 weeks of menstrual age. So during that period, we believe that the baby is quite small and fragile and try to our best to avoid this infection through the breast milk. But before that, I mean, the first 1 week, I think we believe that the benefit from the fresh breast milk is quite important, more than the risk of cytomegalovirus infection. So that's why we just do the fresh milk, use the fresh breast milk. And after that, we start the frozen breast milk until 34 weeks. And after that, we believe the baby is already mature enough to receive the cytomegalovirus. So we just stop it. So this is our regimen.
Yeah. I think the same practice in Australia also. We don't check the CMV in the mom's breast milk because we actually want to encourage the like breast milk, mom's breast milk. And then we just like do the screening of the CMV infection in the baby. Yeah. I think I will restrict because we need to progress, but I need to ask you about your because I noticed that you started HMF when your baby tolerates 50 mils per kilo. Do you have a lot of feeding intolerance or neck related to the early introduction of fortification?
Due to the early introduction of
Because
fortification.
usually we started when the baby has 100 mils per kilo per day.
Mhm.
That's 50 is brave, very brave. I will just, yeah.
Well, the first idea, the first thing is that we usually don't start the fortifier fully. So if we put this amount of powder to the breast
You
milk,
put like
then the start
22.
dosage is 1/4 of the
Oh, you
full.
give like 22 calories, not the 24 calorie.
No, no.
Okay,
So
so you
that's
start
one
a
of the,
bit.
yes,
Hmm.
yes. So that's
Okay.
one idea, and we Japanese are very kind of a how to call it. Mm. We are not brave. So if the baby's abdominal distension happens, then we just reduce it or stop it or something. So we usually not continue it until the baby's abdominal distension will
Settle
it's
at
getting
least.
worse. Yeah, that's
Yeah.
right. Right.
What is your neck rate?
It's quite low. I think almost 0% or
Oh,
something.
wow. Okay. Okay. It's nice to hear from you. Okay. I think I stop here and then I will let Makiko to present her part. And after that, later, at the end, we will ask more of the question there for you. Yeah.
Okay.
Okay. Can we have like CV for Makiko? Nova, please. So, Makiko Noda, she graduated from the College of Medical Technology in Kyoto in 2001. And then she worked as a midwife for 14 years in another hospital. And after that, she became a NICU nurse in Nagano Children's Hospital from 2016 to until now. So like she's been in Nagano Hospital for 10 years. Yeah, so I invite Makiko to share about the topic, the role of NICU nurse. Are you able to share now, Makiko? Yeah, we can see. Yeah, nice. Okay, time is yours. So again, it's unlimited, but I know that you probably has restricted to around 1 hour. That's okay. Thank you.
Okay. Thank you for the introduction. I'm grateful for this valuable opportunity. Halo semuanya, saya Makiko. I can't speak English well, so it may be difficult to hear. I'm sorry. Today, I'd like to talk about nurses' roles for extremely preterm infants at our unit. Thank you. Okay. Let me introduce the nursing system in our unit. In the intensive unit, a nurse cares for 2 babies during the day and 3 at night. In the step-down unit, a nurse cares for 2 to 3 patients during the day and 4 to 5 at night. The ratio stays the same regardless of baby's condition. Even for babies on HFR, nitric oxide therapy, or therapeutic hypothermia. This is the night shift schedule for a nurse on a relatively calm night. We take turns having breaks and naps with the nurse working in the same room. This is the schedule for the midnight hours. The photo above shows our nap room. We also use the family, since we don't have enough rooms, we also use the family consultation room by setting up a sofa bed there. All right, let's move on to the main topic. Nowadays, our goal of neonatal care is not just saving their life, but to reduce their disabilities. I believe that what is required for nurses in intensive care is to support the physiological adaptation of extreme infants. To achieve this, we need to have predictive observation and assessment skills for appropriate care. Now, I'd like to talk about the care of extremely preterm infants in our unit for each item below. First topic is respiratory management. The crucial points of gentle breathing management to protect the lungs of extremely preterm infant. What we care about most is keeping the baby's breathing stable and helping them stay calm. That's why positioning is so important, and holding is also a very effective way to help the baby settle. We adjust the position to maintain good ventilation, and we use holding to support rest and comfort. These approaches are also important for preventing unplanned extubation. Even with minimal handling, we perform tracheal suction only when it's appropriate. To prevent lung injury from oxygen toxicity, we confirm the target SpO2 with the doctor and make frequent oxygen adjustments. I will talk about how to adjust the position of extremely preterm infants born under 22 to 25 weeks. The baby is kept in a supine position for the first 72 hours after birth. The key is to keep their head and trunk in the midline position. This ensures even ventilation and keep their limb in a flex position like a fetal position. We maintain the body position with a sheet that doesn't damage the skin. After 72 hours, a doctor confirmed by ultrasound that there is no IVH, and then nurse begins to change baby's position. In the initial 8 hours period, we change baby's position once, while monitoring changes in blood pressure, SpO2, and VT. Then we widen the range of movement and shorten the intervals. For example, supine position to right side semi-lateral position. Return to supine position, then to left side semi-lateral position. And again, return to supine position, then to full right side lateral position. The pictures show our tips for lateral positioning. Baby's head and back in a straight line. Buttocks and shoulders in the same line. And they should be in contact with the wall. Keep the midline position with pillows. We start changing to the prone position around 7 days after birth. We use a body pillow to keep the baby prone. If vital sign is stable, change position from left and right prone position every 3 hours. The right image is by ultrasound at 25 weeks of pregnancy. We arrange the position mimicking fetal position. This picture shows our prone position tips. To head the body pillow width equal trunk width. Head pillow about 1 to 2 centimeters. Hand is at mouth. Elbows and knees touch the mat and legs. Body pillow about 3 to 4 centimeters. Buttocks and feet aligned. The head pillow is about half the height of the body pillow. If you don't have a fitted pillow, use a towel. Now, I'll show you a video of my team changing baby from supine to prone position. First, the nurse changed the direction of the head. You can see I am, which is a stress sign. So she holds him to calm him down. Once the baby settles, she let them hold the positioning pillow and provide holding support. When she lets go, he extends his legs as a stress sign, so she holds him again. She turns him to the left lateral position. You can see his face softened by her holding. After turning him to the prone position, she places his hands near his mouth to self-soothing. She adjusts the direction of his toes, and then she provides holding. Since he's not settling, she checks for looking and gives him a pacifier. After she sees him calm down and notices his heart rate is coming down, she removes her hand slowly and wraps the baby with a towel. His baby is in a stable phase, so the nurse did the position change alone. But in the acute phase, two nurses do it together. Next, tracheal suctioning is a highly stressful procedure for baby. It's essential to effectively remove tracheal secretions while avoiding pulmonary collapse. In our unit, a closed suctioning system is used, and the suctioning pressure is set at 13 kilopascal. The suctioning tube is advanced 5 mm beyond the distal tip of the endotracheal tube, and negative pressure is applied for 2 seconds before withdrawing the tube. The recovery of secretions is assessed by flushing the catheter with water, and nurses additionally evaluate the presence of secretions through palpation, because repeated suctioning increases the risk of atelectasis. Determining the appropriate interval between suction episodes is crucial. We should always keep GER in mind when managing the respiratory status of extremely preterm infants. If we see signs suggesting reflux, we intervene by slowing the feeding rate and increasing the head-up position to help prevent aspiration. Let me introduce how we secure the endotracheal tube in our unit. We start by applying a skin barrier swab, and then we secure the tube with 2 pieces of tape. At each care time, we check the fixation, and if the tape is not lifting, we replace it. Securing the tube is important, of course, but we believe the most critical factor in preventing unplanned expansion is observing his behavior and positioning them so they can stay calm and settled. After extubation, we manage the baby on Neonatal. While using Neonatal, abdominal distension is pretty common. To deal with that, so sometimes place an extra feeding tube and release the air in the stomach. We also keep that extra tube open so that the air can escape on its own. And we increase the frequency of bowel care. Normally, extremely preterm infants get bowel care 3 times a day, but when the distension gets worse, we do it around 6 times a day. I'll talk about skincare during Neonatal later. Next, I'll talk about IVH and how we prevent it through nursing care. So, these are the main points we focus on to prevent IVH. For 22 to 25 weekers, we keep them deeply sedated and use minimal handling during the first 72 hours. But that doesn't mean we do nothing. We step in only when it's really necessary and at the right moment. And whenever we do anything, we make sure their condition is stable first. Positioning is really important for keeping the baby calm and comfortable. To decide when and how we should do something, we carefully watch the baby's behaviors. Based on our synaptic theory, we watch for stress signs, what's causing them, and whether the baby needs our support or not. This helps us judge the right timing and which procedure of care. These are the key points for temperature management during resuscitation. Once we close the incubator doors, the baby can warm up fast, so we check often and adjust temperature. We also use heart rate trend as our reference. This is our guideline for temperature management in infants born before 25 weeks. When we adjust incubator temperature or humidity, we consider not only age or body temperature, but also weight, skin maturity, skin issues, urine output, and sodium levels. Importantly, reduce noise and light exposure. We minimize incubator door noise and silence alarms quickly. During X-ray imaging, we try minimize noise and vibration. We cover the incubator to exclude light, and when observing the baby, we cover the eyes first, then turn on the light. For painful procedures, we provide pain management. A nurse stays close, holds the baby, and may use breast milk, sucrose, and a pacifier. We also involve parents. Now, let's move on to infection. Here are the infection control topics I'll go over. Our staff always carry hand sanitizer on them. We also keep sanitizer at each baby's bedside, so families can also use it. We strictly follow these 5 movements for hand hygiene. At the start of each shift, we clean the incubator and the patient items with sodium hypochlorite wipes. We avoid sharing equipment as much as possible, so things like thermometers and stethoscopes are kept patient dedicated. When we take shared item from the shelf, we perform hand hygiene first. This is our usual practice of IV injection. First, wipe 10 times in both directions. Then wipe twice in one direction using different surface of alcohol wipe. Next, about skincare. We place the baby on a hydrophilic polyurethane foam dressing and sheet mat. The sheet mat helps relieve pressure. All linen that touch the baby, including towels, are sterilized. We don't use ECG monitors, and we adjust the tubing so it doesn't touch the skin directly. We wrap the stethoscope with silicone-coated gauze before using it. We use a non-adhesive SpO2 probe, and we protect the skin with gauze before putting it on. I'm sorry. For the buttocks, we put Vaseline and place a non-adherent dressing like Marilyn, then set the flat diaper. Because the diaper gathers can cause skin issues. When skin damage possibly happens, we use prophylactic hydrocolloid dressings. Skin issues often happen where the skin is in tight contact. We check those areas based on the baby's activity level and keep them as dry as possible while maintaining good positioning. Sometimes we place silicone-coated gauze between the skin and the contact point. Next, I'll talk about how we manage skin problems when they happen. We take a culture to see if the wound is infected. We clean it gently with warm saline. We position the baby so the area can dry as much as possible. We slowly lower the incubator humidity. If there's no infection, we apply a protective dressing. If there is infection, we keep the wound uncovered. It's the picture, no infection. We use a hydrocolloid dressing. We take off the interface every 3 hours. Next, nerve management for skin. We take off the interface every 3 hours for pressure relief and quick check. We remove the hat once a day to wipe the skin and check the area, for example, behind the ears. We place Shika care between the skin and the mask. When use nasal prong, we place dual active. And we place a piece of cotton under the belt. To help the baby develop normal flora, we place a parent's scented towel. We also use breast milk with a cotton swab. We encourage parents to touch, hold, and skin to skin. Next topic is family-centered care. Family involvement is essential for supporting the baby's development. Here are the key ideas in family-centered care, as Ryo said. to support early bonding once the initial resuscitation is finished. We let the parents meet their baby and touch them, even if it's just with their hands. We celebrate the birth and say congratulations to the parents. In the NICU, we give them roles. We start with simple things like gentle talking and touching. If the baby's condition is stable and the parents feel emotionally ready, we step up their involvement like diaper changing or giving breast milk through a feeding tube. And it's not only about doing care. We also learn together to see breathing, skin, abdomen, and any other baby's behavior. We give parents small roles and then offer positive baby-focused feedback, like your holding really helped your baby to be calm. That kind of feedback builds their confidence and helps them engage more, which supports the baby's development. When we share the baby's condition, it's not just one-way information from the staff. We ask the parents what they've noticed and make decisions together. Like, do you think we can win off the high floor today? Being asked helps parents improve their observation skills. During daily visits, nurses ask parents about the baby's breathing, skin color, and abdominal fullness, and this naturally builds their confidence. We also don't decide how they spend their visit time for them. We ask and plan together. We work with the parent to decide what's best for their baby. These small moments of shared decision-making help parents become more independent and reduce anxiety after discharge from hospital. We also give them a roadmap to home early in the admission so they know where they are and what steps remain. Nurses who care for extremely preterm infants play many important roles. We listen to the baby through their behavior. We listen to the family, and we keep close communication within the medical team. By bringing out the strengths of the baby, the family, and the staff, we aim to rescue and to reduce disabilities for survival and the family's happiness. That's all for my presentation. I look forward to improving our practice together. Terima kasih.
Thank you so much, Makiko. I would like to acknowledge that the NICU nurses play really a critical role in like stabilizing the baby, especially very sick infants. And then I think the role of, if I may say, Rio, the role of nurses is are much bigger than the doctors. Because the
agree.
doctors,
I
they are
totally agree.
bossy.
Agree, Dok.
They are
Agree.
bossy. I don't like the bossy doctors. I like the doctor who can work together with the nurses. Okay, it's very good, Makiko. And then I just got the messages from the nurses back home that they really like your presentations and they really wants to learn from you. Like, okay, let me give summary in our language, especially for our nurses. Thank you. Jadi teman-teman sejawat sekalian, terutama para perawat, jadi apa yang tadi disampaikan oleh NICU Nurse Makiko, jadi sangat penting untuk perawatan bayi, bukan hanya bayi prematur ya, bayi secara keseluruhan. Apa yang saya observe, karena saya pernah datang ini ke Nagano Hospital, jadi perawatnya ini sangat gentle di sana ya, jadi sangat gentle bagaimana dia memperlakukan bayinya. Tadi mungkin video yang berubah posisi itu bayi agak besar berarti dia kemarin bilang di atas 30 minggu dan bayinya sudah relatif stabil. Tapi tadi ingat message-nya, untuk bayi yang lebih kecil dia butuh tidak hanya satu perawat untuk merawat, dia harus 2 perawat. Jadi saling satu sama lainnya saling mengingatkan. Oh ini yang satu menjaga kenyamanan bayinya, yang satu ngeliatin itu jangan sampai heart rate-nya. Jadi pesan untuk teman-teman perawat terutama kalau melakukan apapun ya, positioning, kemudian suctioning, ya apapun, pokoknya memegang bayi itu dilihat itunya berfluktuasi nggak, kita kasar nggak sih, berfluktuasi nggak heart rate-nya, saturasinya, karena itu sangat penting terutama nih bayi-bayi kecil yang kita nih ekstrem prematur 22-23 minggu gitu ya. Jadi tapi tadi nomor 1 ya yang dibahas adalah bagaimana posisi di 72 jam pertama. Nah, dia memberikan sedasi dengan fentanyl pada bayi 22 sampai 25 minggu ya di 72 jam pertama. Nah, terus dia posisinya kepalanya midline dulu selama 72 jam pertama dan minimal handling. Ya, dia setiap kali mau menyentuh bayi atau melakukan sesuatu dia berpikir dulu, ini penting nggak sih? Ini merubah nggak sih? Atau ini malah mengganggu bayinya menjadi tidak nyaman. Baru setelah itu diposisikan side lying gitu ya. Sambil tadi memperhatikan, jangan lupa antara satu posisi dengan posisi lainnya itu nggak langsung. Jadi tunggu sekian menit atau lihat sampai bayinya settle, tenang, heart rate bisa turun, nggak naik gitu ya. Kalau perlu ditawarkan itu dikasih empeng ya, pacifier. Nah, terus yang kedua mengenai suctioning. Suctioning itu tidak rutin. Jangan nganggep itu nggak ada slam itu di suction. Jangan, itu sakit di suction ya. Terus sebisa mungkin pakai closed suction. Dan yang sangat penting ya mungkin nanti ke depannya kita perlu belajar terutama perawat adalah mencegah terjadi namanya accidental extubation. Jadi nggak boleh tuh terekstubasi secara tidak sengaja, itu nggak bisa. Jadi tadi diajarkan gimana caranya fiksasi ETT gitu ya. Kemudian juga posisi kepala tadi, kepala lebih tinggi gitu ya, itu untuk mencegah GERD. Dan untuk abdominal distension tadi dia menyebutkan pada bayi-bayi yang ada abdominal distension tuh bisa karena dia di stomachnya, di gasternya itu banyak udara. Nah itu seperti itu dipasang NGT yang kedua untuk namanya venting, jadi untuk ngeluarin udara. Tapi kalau ternyata udaranya bukan di gaster, udah di ke bawah, maka dia cara lain adalah tadi mencegah yang namanya konstipasi, mencegah yang namanya dilatasi usus-usus dengan memberikan enema. Nah, enemanya tadi dia bilang minimum 3 kali sehari. Minimum ya, kalau dia bilang abdominal distensionnya lebih, maka dia bisa berikan sampai 6 kali sehari ya. Dosisnya nanti kalau misalnya ada yang berminat kita bisa share untuk dosisnya. Kemudian temperatur manajemen, buka tutup inkubator harus diperhatikan. Bayi ini udah stabil belum untuk temperaturnya? Kalau perlu ditutup dengan plastik. Plastiknya kalau perlu yang itu, yang namanya double, yang biasa buat wrap itu. Jadi dia ada 2 lapisan. Terus jangan lupa di cover matanya untuk cahaya, karena bayi itu kalau kena cahaya yang terang itu dia stres gitu ya. Terus manajemen nyeri penting untuk diberikan sukros ya. Skincare kita terus terang kita harus masih banyak belajar, terutama juga banyak dressing yang kita nggak punya di Indonesia ini ya, karena kalau misalnya bayinya sampai infeksi karena perawatan karena cedera kulit ya, ini merupakan maksudnya gitu kita udah susah-susah memelihara bayinya resusitasi dengan benar, dikasih nutrisi yang baik, kulitnya lecet-lecet terus jadi infeksi, jadi susah jadinya nanti bayinya bisa meninggal karena infeksi gitu ya. Nah, tadi dibahas mengenai salah satunya kalau dianggap kulitnya terlalu moist atau ini bila perlu suhu humidity-nya diturunkan. Kita tahu humidity pada bayi-bayi kecil itu dia diberikan paling tidak sampai umur 1 minggu. Nah, setelah 1 minggu humidity-nya mulai diturunkan ya. Terus jangan lupa mengenai nasal care tadi dibahas ya. Ini saya lihat rada neglect nih, agak nggak diperhatikan ya. Jangan sampai hidungnya sampai bolong tuh. Nah, itu mungkin nanti kita akan bahas lebih lanjut mengenai nasal care. Sering ada cedera di bawah telinga, di belakang telinga, kemudian di dahi ya. Bahkan kepalanya jadi penyok-penyok biasanya kalau nggak pernah dirilis itunya si headnya dari yang si pep headnya itu. Nah, yang terakhir adalah family centered care yang mungkin nanti kita bahas secara khusus ya. Okay, so now I have summarized and then we would like to get some question from the nurses for Makiko. Yeah, this is interesting questions because I think Makiko's presentation mentioned about that you didn't use for ECG monitor initially, and then if you use, can you describe the specification of the ECG what is it, sensor that you use regarding probably the size or how thick that one or how you prevent the skin injury?
So we have just talked about this question because we have a translator and we already knew it. And well, of course, we have the purpose. Routinely, we use this ECG monitor, of course, for all the baby.
Okay.
But if the baby is very premature, like below 24 weeks, I think, 25 weeks, we never put it during the first 3 days.
Yes,
And the purpose, of course, is to protect the baby's premature skin. So the size of the ECG monitor for each is very small, like the needle of the forefinger. It's very small, but it's quite sticky, you know. So if we once put it on the baby's premature skin, it may harm the baby's skin, or when we have to remove it, it is so troublesome. So that's why we just forget the ECG monitor for the first 3 days and do the care and the treatment without it. But I think we can handle it because without any heart rate monitor, we can see the pulse rate, which is almost identical to the heart rate. And when during the first 3 days, I think without heart rate monitor is much more beneficial than with monitor.
So if you do use the ECG monitor, do you use the remover? Because in Australia we use the remover, so easily you can remove the sticky sensor.
We do.
Okay,
We do.
that's very important because in Indonesia we don't. I mean, in some hospital they don't have the remover.
의무가ない.
Yeah.
Yes,
Yeah,
and
good.
I think Makiko would like to add something.
But
Yes.
we use ECG monitor when resuscitation, but we use シリコンガーゼ の上に、ECG モニターのプロブを貼って、レサシテーションの時だけ使ってるって言ってもらってるので。
So,
Sorry,
well,
repeat, yeah.
one exception is during the resuscitation.
Resuscitation,
So,
yeah.
when the baby is born and carried to the incubator, we start the resuscitation. And during the resuscitation, we put the ECG monitor. But Makiko said that they put the ECG monitor over the silicone gauze. So to prevent the sticky monitor to be stuck to the skin. So they then easily remove it after the resuscitation and then continue the observation without it.
Okay, yeah. And then someone asking about when you start, this is actually the question that I asked you before, when you start like skin to skin care or kangaroo mother care, when the first time you started in your
That's a
baby?
good question. So nowadays, I think the timing of the first skin to skin is getting earlier and earlier nowadays in the world. So for example, in Sweden, they just do it shortly after birth, like within some hours. In Finland as well. But it is unfortunately not our practice at this moment. So if the baby was born 22 or 23 weeks, the first skin to skin may happen 1 month after the delivery. It may be earlier if the baby is more mature than this kind of a baby. But we have to make sure that the baby's respiratory condition and the circulatory condition is stable. So then it might be 1 month after birth.
Yeah, because again, as I gave comment to you before, the practice in Australia is different. So usually, let's say if like 22 to 23 weeker, we will start at least to give mom chance to do kangaroo mother care at least at 1 or 2 weeks of age already, because by that time we assume the baby already stable at least. Yeah. Okay, so next question about how, this is actually the question that I was about to ask before, about oromotor stimulation. Did you do like specific oromotor stimulation to help the baby to have, so you know that actually babies start, like normal baby, they will start sucking reflex at around 35 weeker, right? But extreme preterm infants, they will start like later. And also some of them will develop oral aversion. So what do you do actually to avoid oral aversion and to promote as early as possible the sucking reflex?
So we have already talked a little bit about this topic as well. And first of all, we about the sucking. So when to start eating from the mouth? It's 35 weeks of postmenstrual age when we start the oral feeding. And before that, of course, we try our best to do something to promote the development of the oral feeding. And the first thing Makiko mentioned is that to give this
breast milk swab.
The swab, the cotton
Bud,
swab.
yeah.
Yes, in the mouth, so that they can start sucking it with the feeling of the breast milk. And of course, we every now and then give the pacifier for the baby, so that not only they can soothe themselves, but also to promote their sucking skills. Do you
Do
have
you
any
see
other?
a lot? Do you see a lot of oral aversion in your unit?
Unfortunately, yes.
Because again, depends on like the way you do suctioning. Is like also when you also insert the NG tube also can cause the oral aversion to the baby.
Exactly. So what I saw in Finland was that in Finland they insert everything from the nose.
The nose,
So
okay.
they insert the endotracheal tube from the nose and the feeding tube from the nose. and EDA
From
catheter
which
from the tube.
gestational age? So usually after 34, 35, then we put in the nose. But
No, from the
what happened
beginning.
from the
beginning.
beginning?
So
Okay.
even the baby was born 23 weeks, they just insert the endotracheal
To
tube
the
from the
nose.
nose. So
Yeah,
this is
that
their
actually
practice,
makes
but I think
sense.
this
Yeah.
is very good for the baby's development of the feeding ability.
Yes, correct. Yeah. And then I will not comment for the parental visits here. And then here, there is a question from Dr. Ashari that in the video, he saw that the nurses use gloves to touch the tiny baby. Is that your practice? Is your for own protection, or like whether own protection means if the baby, let's say, colonized with like MRSA or something else, or it's like you do it regardless if the baby doesn't have any colonization, you always wear gloves. So can you just explain about that?
Yes, thank you for the question. So this is our routine care for all the baby in the NICU. So we always wear the gloves to
Okay.
touch the baby. And
Okay.
if the baby has, say, MRSA or something, we check regularly the baby's natal swab to see if the baby has MRSA, maybe once a week or something. And if the baby has it, then we need to do something more, like not only putting the gloves, but also putting the apron or something,
Protection.
so that
Yeah.
we won't, that right, transport the
Yeah.
bacteria to other
Yeah.
babies.
And this is interesting question. When you start bathing the baby, like the tiny baby.
That's a good question as well, I think.
Yeah.
So I don't know the practice in Indonesia, but in Japan, everybody likes to bathe. I mean, we are kind of well, persons who like the cleaning or something. So we take a bath every day. And it's not only for us, but also for the babies. So and talking about the first bathe, so the idea is like this, that if the baby was born, baby preterm, then we first start wiping the baby's body. Then if the baby still have high flow or something when their skin is mature enough, say 30 weeks of postmenstrual age, then we bring the, what is it?
Base.
The
Base or
bucket.
some,
Yeah,
yes,
bucket,
yes,
like
the
big
big
bucket.
one
Yeah.
to the bedside so that we can put the baby in the bath just beside the baby's bed. And if the baby's breathing get mature and get rid of the breathing support, then we just take the baby to the bathing area. Well, we have the special bathing room. So that we can bathe the baby easily. So this is a practice. So maybe the answer is that about 30 weeks of postmenstrual age.
Yeah, and depends also how stable is the baby. Yeah.
Exactly.
This is actually the repetition I noticed from Dr. Asari because we didn't discuss before. So when you do like kangaroo mother care, how, like whether you ask the parents to, because we come from different culture, different background and different probably socio-economic background in Indonesia. So did you actually ask the parents like regarding they need to clean their body, let's say if they travel, if they use like public transport and they need to change the clothes before or whatever? Did you say something to the parents before they did the kangaroo mother care? Yeah.
Well, Makiko said that there's no kind of a suggestion or guideline or something for the parents. First of all, we are in the remote place, like the suburb place. So nobody comes to a hospital by public transportation. All of the parents are coming by car. So
Yeah.
they're not will be soaked to the sweat or something. And the next one is anyway, during the skin to skin, they will sweat,
Yeah, correct. Yeah.
because the baby is quite warm. So that's why we won't say anything about the cleanness of their body. They just come here and start the skin to skin.
Yeah. I think that question like will the answer or like the practice will be different from like different setting. Yeah.
I agree. I
Yeah.
agree.
And then the next question. So again, this is actually about when the baby start oral feeding, and let's say they develop like desaturation. So we are thinking whether there is micro aspiration. So how you manage? I assume that you have like speech pathologists there, or you have like modified barium swallow test just to see whether the baby has micro aspiration. So what is your practice there?
違う
いや、まあ、それも含めてね、誤嚥があるかどうかっていう話でね、それをどう判断するか。
まあ、唾液、口の分泌物のミルクっぽさ。
So is it the oral feeding? Oral
Uh,
feeding.
Yes, so when you
Okay.
introduce like some suck oral feeds, and then you notice the baby has
Puffing or
desaturation.
something.
And then I know like in Australia, we involve the speech pathologist, and then if that happen and we suspect there is micro aspiration, then we will do the barium, like modified barium meal study, just to see whether there is like micro aspiration, or the way usually we put on side lying, like giving the bottle feeds by side lying. Yeah.
Well, talking about this desaturation during the oral feeding, I think
Correct.
the most common reason of this desaturation is that the baby just forget breathing.
Yes.
So in this
Because
case, we
immaturity.
exactly. So in this kind of a case, we will just wait for the baby to mature their feeding ability. But if we suspect the baby has a microaspiration, like if the baby has not only this desaturation, but also has some symptoms like coughing or something, then we might suspect the microaspiration. But I don't think we do something. Oh, of course, we can ask the physiotherapist to for the practice of the oral feeding, the eating ability, and promote it. But I think just it. We never use any test or something to assess it.
Yeah. And then next question about to prevent pressure injury. How frequent you do the positioning? Let's say stable baby, whether let's say if like in Australia, this is the way we do it. So if let's say the baby on 2 hourly feeds, so they can position the baby because every 2 hours, right? They can make it like every 4 hours, every 8 hours, change to different position. And then in 3 hourly feeds, usually we will change every 3 hours because they are more stable. But if the baby just one like hourly feeds, and especially they're still small, we don't change the position up to can be like 8 to 12 hours. So what usually you do in your hospital?
Are you talking about the very preterm baby or
Yes, this is the very preterm, like extreme preterm infants.
対抗のはずだよね。So as Makiko told you that during the first 3 hours, if the baby needs a sedation like to prevent IVH, so I mean the gestational age is about below 35 weeks or 25 weeks or something. We never change the baby's position during the first 3 days. I mean 72 hours.
Yeah, 22, 25 weekers. We aware that you have explained that you give sedation and don't change. You put in on midline. We aware, but after that, how frequent you change to side lying, to prone position, to another side lying, like how many hours? Every how many hours?
毎日週以降だったら、でも多分、24時間とか経ってからじゃないかな。それこそ25週とか6週ぐらいの、IVH のない子ってことだよね。
そうだね。
だったら多分、
1日はまず業外で。
1日は業外で待ってるんじゃないかな。もうあとはその、
落ち着かなかったら腹外するとか。
腹外まではさすがにしないな。
その辺だったら。
でもまあ1日後ぐらいじゃない、ざっくりと。
まあ、呼吸とか循環ある程度落ち着いたらっていうね。
うん。
So we were talking about the baby who were born 25 to 6 weeks, for example. So she said that they usually wait for 24 hours to change the baby's position. So to wait for the baby's respiratory and circulatory condition to be stabilized. Then after that, they start changing the baby's position.
So do you always, let's say now the baby's stable, do you always wait up until 24 hours?
すごい落ち着いてたとして、24時間待つみたいな。
もうちょっと早い時はあるかもしれないな。
So it might be earlier if the baby is stable.
So depends on the condition. Yeah.
Exactly.
Like I mentioned, like in Australia, the way usually like the smaller the baby, they usually change the position every like 12 hours, probably 8 to 12 hours. Yeah, and then if like they are, let's say already 4 to 6 weeks, then they change the position every like 6 hours or 4 hours, depends on the condition. Yeah.
子供も追加である。
スタート、そのポジショニングを変え始めても、多分最初は3時間ごとじゃなくて、多分勤務に1回とかぐらいからスタートすることもあるし。
So she's also talking about the frequency of the change in the baby's position. So as you mentioned, that the beginning of the change in the baby's position, they might they might want to change the baby's position not so often, like every 3 hours, but say every 6 or 8 hours.
Yeah, definitely. Yeah. Okay, so I try. Oh yeah, there is Nova, can I ask? So I think one nurse, she wants to ask directly. So nurse 3,
Yes,
Iya,
Nastri.
yeah,
Can.
okay.
sebentar. Ya.
Yeah.
Hello, Makoko and Rio. I'm nurse and I have a question. I'm absolutely amazed by this premature baby's journey to finally being able to go home. And I want to ask the baby was in the hospital for about 6 months, which must have been incredibly expensive. Who cover all these costs? Is baby use insurance or Japan government cover all the costs? And I have another question. I think we share a common challenge.
You're muted, 3.
You mute.
Dari awal apa?
No.
Okay.
And then I mute myself. So Nova also mute yourself for now. And 3 is speaking.
We have common challenge regarding what Rio mentioned. Sometimes when a baby is ready to discharge, the parent aren't prepared. So the baby ends up being readmission. Okay. What's your strategy? Does your NICU team use to prevent this readmission? Because in our unit, our challenging is how to maintain the parents still involving to caring the baby. Sometimes the parent is excited in the first, but after that, the parent not routine come to hospital again, so we don't have much time to learning what the parent must learn to the baby go home to get up to discharge baby. Okay, is clear for you?
Thank you so much for the questions. I think both questions are very important. So talking about the first question, so about the cost and who pays for that. Well, we Japan fortunately have the national kind of insurance system. Everybody has to be in the insurance, and the government. So I mean, the government covers almost all the cost we paid or we spent in the hospital. But of course, the parents has to pay some of them I think, for example, the cost of the diaper. なんか他にありました。
洋服のレンタルとか。
And the rent for the clothes of the baby. Of course, well, after some months, they can bring their own clothes to the hospital, but until then, they have to borrow clothes from the hospital. So they have to cover that. But I think that's it. It's a small cost compared to the huge amount of the medical cost. No? Okay. She said it's not a small amount, but yes. But anyway, almost all the costs are covered by the government. Yes. And did you have any other comments?
あとはその通院のためのコストがすごくかかるよね。
Yes. And well, aside from this medical cost, they also have to cover the cost to the hospital and back. So for example, as I told you, almost all the parents has to come to the hospital by car. So they have to pay the fuel cost or something. And we're very good large area. So some of them have to pay for the highway cost. I mean the toll roads are everywhere in Japan, so they have to pay for that as well. So that must be big challenge for the parents to often come to the hospital. So that might lead to the second question that not all the parents can come to the hospital every day. That is unfortunate. So, for example, in Finland, the system was like this, that parents can stay overnight in the same room, which is super helpful for the parents, especially for those who live in the far away from the hospital. And well, talking about the second question about the readmission and how to prevent this readmission and how to promote their involvement in the care in the NICU. So I think this is also a very important topic to talk about. And the first comment is that we can't force parents to come to the NICU. Of course, technically or financially, they are usually not allowed to come to the hospital every day. So we can't force it. But instead, first of all, we like to make the best use of their stay in the NICU, like not being making them just bystanders, but we'll try to involve parents in many ways, like not just asking parents to, oh, please to change the diaper, but to ask parents to get more interested in the baby and their behavior. So like using the special communication techniques, we try our best to make them being interested in the baby. And of course, if once they think that they're interested in their baby and they create a good bonding with the baby, I think they're motivated to come to the NICU more often than the beginning. So I think this is something we can do, not just asking parents to do something, but just asking parents what they want to do for the baby or something, so that they can kind of actively being involved in the care and what is happening around the baby. And I think, well, this kind of a communication has been developed using the training program, the close collaboration with parents, as I included in my presentation. And after the training, we found that many nurses doing the similar kind of active communication. And after that, we found that many parents are not as anxious as before the training. So they're actively thinking about their baby and how to cope with that. And as a result, we found that there are less phone calls happening to our hospital. And I'm sure, I didn't have any statistics, but I'm sure there are less admission, which is caused by the parents' anxiety or the non-readiness for discharge in the NICU.
Yeah,
Am
I
I
think
answering your question right?
Rio, I just add based
Yes.
on our discussion before. So 3. So in Japan, before especially anxious parents, and then in the extreme preterm infants, they offer rooming in 1
Oh.
or 2 days before discharge. So in the rooming, like during the rooming in, parents will have their babies in the room. They will do everything
Okay.
like they are at home. And then if they need help, then they will ask for help. Otherwise, they will look after the baby in the room by themselves.
Okay, Dr. Willy.
Yeah,
Thank
that's
you.
that we don't practice in Indonesia.
Yeah.
Yeah. Okay. And then, okay, terima kasih. Thank you,
Thank you, Rio
Thank you. Our pleasure.
and Makoko.
Yeah.
Thank you.
Makiko.
Oh, Makiko. I'm sorry.
Yeah. Okay, so I would like, this is a really interesting question from brief 4. I would like the doctor to ask so Dr. Medi Ramadan, can you just please unmute yourself and ask the question? This is regarding the polar protocol resuscitation. Means like during the resuscitation using the high PEEP strategy. So if you're still here, Dr. Medi Ramadan, so he's asking about polar protocol for resuscitation. This is about dynamic PEEP strategy starting at 8, and then the highest CPAP, like PEEP, is at 12 if the heart rate under 100. So basically to recruit, like to recruit the lung. Do you know at all, or do you use in Nagano Hospital, Rio?
No, actually no.
This is probably just study, probably. Yeah.
I knew the idea, but I never know the details of this strategy. I'm so sorry.
That's okay. So I think just to complete other questions, there is a question about how you consider like to use fluconazole instead of nystatin for fungal prophylaxis in like preterm infants.
So the idea is to prevent candida infection.
Yeah.
Am I
Whether
pronouncing right?
your fungal infection rate is high or low. I assume it's low.
It's quite
Because
low.
yeah, if the fungal infection rate is low, so to cover with nystatin prophylaxis is already enough rather than so usually fluconazole is you have like higher fungal infection
I
rate.
understand.
Yeah. So what is your consideration? Because obviously fluconazole, has the side effects of the like more hepatotoxic, and also can introduce the the what you call it, like fungal resistance, because like in Indonesia now we have more non-albicans candida because of this practice. We use a lot in the past. We use a lot of fluconazole. So now our rate of non-albicans candida is higher, much higher than the candida albicans. Do you have your own consideration based on your study? Why you use fluconazole, not nystatin?
Thank you so much. Well, to be honest, it never came up to my mind to change it because we seldom have the difficulty in handling candida or any fungal disease. So sometimes we have the skin trouble with the candida or something, but it's not always like this. And if I remember correctly, well, from my experience in Nagano, I just one case of candida infection in the whole body. But so it's not at all common, I think. What do you think?
に
candida 感染って結構ありますか？
いや、あんまりない。
So
Never
it's quite rare, and that's why, sorry, we never have the opportunity to change our practice. So I think this is the only reason why we still use fluconazole as a prophylactic purpose. But I think you're right. We need to change the practice.
I think nystatin is enough, honestly, for your unit.
Okay.
Not like us now, like the unit in Indonesia, we just changed from nystatin to fluconazole because
Mhm.
now somehow increase again the fungal infection rate. Okay, anyway, next question about probiotics. Do you do your own study when you consider using the bifidobacterium rather than the lactobacillus?
That's a good point. And well, I myself would like to change it to bifido, to another
Or like
one.
combination, because in
Oh
Australia we
yes,
use
nowadays
combination.
it's a combination. Yeah, that's
Yeah.
right. That's more preferable. Well, the problem is that we started this practice long time ago, and almost nobody know why it is started. But I heard that it is because it is a company who provides another kind of a not the fortifier, but I think the formula or something. So this company also provide another thing. So that's why we have to continue using the same thing for a long time. But nowadays, I knew that there are a lot of evidence showing that well, having this combination treatment or prophylactic use might be beneficial for the babies to develop a good gut microbiome or something. So I think, well, our practice is like this, and we have a good result regarding neck complication or something. But I think our practice is well not better than what you think.
Yeah, I mean, like depends on. I mean, I noticed that every unit has their own policy. Yeah,
Exactly,
yeah,
exactly.
and usually some of them based on the local study. Yeah, that's
Mm,
why I asked, did you do
mm.
your own
Oh,
study or not?
we
Yeah.
don't have any local study we conducted in our hospital.
Yeah. Okay. So I think one more question, unless there are more questions from the audiences. So one doctor is interested in your HM, like the the milk fortification, whether you use from human or cow's
Mm.
milk.
Now we just use cow's fortifier,
It's
but in the
expensive.
future we'd like to use it. Yeah, well, not only this money issue, but also I don't think it's available in Japan.
Mm-hmm.
We have just conducted the multi-center study maybe some years ago, and we got a result, and maybe in some months or years, it will be available. Of course, we have to cope with this financial problem. But anyway, it will be available, but now it's not. So that's the reason.
Yeah. Okay, I would like to offer for the audiences whether you still have more questions for Rio and Makiko before we close. I think our discussion is very fruitful today. Thank you so much. I mean, we learned so much from both of you. Are there any questions from the audiences?
Dr. Dilek, may I
Yeah.
ask one question for Makiko?
Yeah.
Okay. Hello, Makiko. I'm Novardian, head nurse in Neonatal in Ciptomangunkusumo Hospital. I want to ask you, we have a big problem in our unit. Many extremely low birth weight baby have a difficult with feeding because it's a reflux. Is it the same in there? What the nursing intervention are provide? Signs some baby experience delays discharge due to recurrent reflux, and some our babies are discharged harm with NGT and OGT. Once again, I saw for your video for pressure injury prevention, you are using hydrocolloid dressing. How long are they used, and until what age are hydrocolloid protection pad applied to the body for the baby? Maybe this is my question. This is clear?
Sorry, the first question is about
Reflux.
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 We have a big problem about reflux. Our
Reflux
baby,
means
yeah.
Biar dapat sertifikat dulu.
What reflux?
It's like GERD.
Gut.
Because like in
Ah.
Indonesia, we the way we do it is we might give like PPI and especially like positioning, yes, and then PPI, and after that probably use the pump like continuous feeds, but they've never done transpyloric before, and then they will have like difficulty if the baby has severe or like ongoing reflux. Then like some babies will be discharged with the feeding tube. Yeah.
So the first of all, I think the treatment or the how to cope with this reflex is almost the same. So once we found the baby has a reflex or the signs of reflex, like we detect that the baby has milk or something in the mouth, even when the baby is not eating from the mouth. So if the baby has this kind of symptoms, or if we suspect that the baby has a reflex, then first I think the position is important. So first we set the baby to the head up position. And the next thing is to prolong the feeding time. So it's usually say 20 or 30 minutes, but they extend the time to 45 minutes, 1 hour, or continuously even. But if not effective, then we will introduce the PPI or medication, maybe the Chinese medication. I heard that is also beneficial for this condition. But if it's not effective, I think then what I think we just put the powder in to the what is it?
Thickener. You use thickener.
What is it? To increase the thickness of the
Yeah.
milk.
In Indonesia, we don't have thickener, but in Australia,
Okay.
we use thickener also.
Yeah.
Can be like a quarter thickener or half thickener.
So if the condition of GR, I mean the reflex is quite severe, then we sometimes have to ask parents to feed the baby like this at home as well. So of course it's a little bit troublesome for the parents. So we'd like to end this kind of a thickness treatment in before discharge. But if not, then we just ask parents to continue the same practice. Do you have any other things?
もう家に帰るぐらいのこの
どっちでも。
っていう話、ED チューブ入れたりすることもあるよね。その話ってしてない。
So I talking about the baby who is about to be discharged or in the middle or the early phase of the admission.
I think in the middle until during the discharge preparation. Yeah.
So if the baby is still on the acute phase, we might want to insert this transpyloric tube. But I think it's only for those who are in the acute or middle phase. Do you have any other idea?
どうするだろう。でも吐いちゃう方ってことだよね。
I think, I will tell you, Rio, because I try to understand or like why, because, I've been working in Australia, right? And then I noticed that some practices already done by the NICU in Australia, but they don't have good survival and also long-term outcome as you have. I think the big difference, not all units in Australia use transpyloric. So I notice, like I work in, let's say, 3 different states, and then only one state use transpyloric tube. And now recently, the unit where I work in Sydney start using transpyloric. And also the other thing that we don't use routinely in Australia is about like enema, which now become more common, but before around 10 years ago, it's like big no It's like a big no for all the neonatologists to give enema for the babies. I think first, what I noticed the difference, you use sedation in the first 3 days, which is very, I think it's common sense, I think, because in that the baby is very sick, and then if the baby get, like, let's say agitation or pain, and then it will increase the intracranial pressure, it will trigger the IVH. And then about to prevent the fluctuation of the oxygen or like abdominal distension, also very important, because like, so the management of GERD and also constipation is very important. So I think the big message, what I learned from you, because the difference, especially developed countries, there are the three things. One is the sedation, and I think about the midline position things we have done, but only the sedation we don't do. And the constipation and the GERD management, yeah, we need to do like more, like in Australia. And also NAPHA. NAPHA is not used widely in Australia. So, yeah. Anyway,
I think
For
we have
pressure
to answer
injury,
you another
pressure
question,
injury. Sorry.
like the hydrocolloid question.
Yeah,
Yeah,
hydrocolloid. Yeah.
this is the same for like hydrocolloid, Dr. Lily.
貼る期間ってこと。もし貼ったとした
ま
ら、大体、
Hmm.
そう傷の時、予防
Soalnya
的
hydrocolloidnya tipis
So
seperti
I talking about the situation where the baby already has a wound or kind of a prophylactic use. Hydrocolloid.
に予防的にも使うけど、
So what is your practice? Whether you use as a, because I know that if you use hydrocolloid dressing, especially the thick one, it will avoid the like the evaporation of the skin also. Yeah. So what do you do in as a prevention? Whether you will put hydrocolloid dressing, and then what do you do in if there is a wound there?
傷にハイドロコロイドを貼る話はした。ハイドロフリックポリウレタンフォームが生まれた時に引くやつだけど、
So if you're talking about the mat under the baby.
Oh, the
Yeah.
not the mat, different. The mat is different. Not the
Okay.
there is
Okay.
like
I
some
understand.
I saw in your slide.
大体3-1だと思う。
So maybe 2 to 3 days.
Mm.
And of course, we every now and then check the wound, and if it's already good, then we just remove it. But we also have the kind of a specialist in this wound in the hospital, so we sometimes consult this person, a nurse, to check the wound.
Wound care CNC, like clinical nurse
Exactly.
specialist. Yeah.
Exactly.
Which we don't have, Nova.
We don't have that.
We need to train the
We need to
clinical
train.
nurse specialist for wound care. We are working on
Dok,
that.
Dr.
Yeah.
Lily, itu tadi benar dok. What the type of padding do you use for pressure injury prevention for the baby?
Oh, dia mau pad.
Yeah, she won't explain that.
Tadi, ya itu tadi dia bilang yang underneath. So she's asking about the
Padding.
what you put to prevent the to prevent pressure injury. I think regarding the mat, and then
Under the baby.
I think the
Yeah,
position
under.
also the position of the baby also important. Yeah. So dia pakai yang itu loh tadi yang
Iya, kayak bantal gitu. Itu.
ya
Itu
itu yang kayak
蒸発のための。
シートマットの話したね。
Nah, berapa lama dok gitu?
oh she's asking how long you put the mat, how long?
How long you put them?
So if you're
Let's say
talking
your
about this
baby
sheep
born
mat, the
not sheep mat, the other one. Remember? There is another one.
For urethane from dressing は、3 days.
Oh, only the first 3 days you put that one.
Here, because we starting change
the baby's position.
yeah. なんていうか、摩擦が少なくて滑っちゃってこう戻っちゃうんだよね。
Ah, so it's quite smooth, too smooth to put the baby on the mat if we started changing the baby's position. So they're just sleeping from the sheet.
Oh, understand. And then, I mean, this like very precious times at the beginning, yeah, in the early lives. Yeah, okay. Yeah. I think Nova, as a summary, I think we better invite Makiko to come to Indonesia.
Yeah,
Definitely.
it's must
That's
to
the
teach
easy
our
thing.
to teach
The
our
easy
nerves.
things to do. We invite her to come to Indonesia, definitely. Both
Okay.
of you, Rio, you also come to Indonesia.
Thank
Okay?
you so much.
I
I'd like to
think,
eat a lot of Indonesian food. It's my
yes, definitely. We will
favorite.
serve you many types of food in Indonesia. Okay. So anyway, thank you so much. We've been, when we are very lucky. What is this one? Oh no. The next question about, I don't think this is the practice to give nebulization for thinning the secretion. Do you do it? In Australia, we don't do it.
No.
No. Yeah, this is not the common practice. Yeah. Basically, the
Correct.
problem about humidification, we need to have the humidification, the right humidification. And then the problem in Indonesia, we reuse our breathing circuit. So because we reuse the breathing circuit, so the humidification of all the air coming to the lung become not effective, and then it can create the thick secretion. I think that's the bottom line. So we need to know it's not about do the nebulization. Yeah. Okay. Now I think because of the time is we've been spending a lot of time with you, and then if I say that we are so lucky to have you both here sharing about your knowledge about the management of extremely preterm infants, and we learn so much. So thank you so much for your time, and then come again, or either come or share again next time with our another webinar. Yeah, thank you so much for today. Yeah, and then I would like to return back to Nova to
Okay.
close this event.
Okay, doctor, I think we must take a photograph.
Oh yeah, they
for the
like to
speaker.
make a photo.
Okay. Ayu. Okay. First slide. Smile. Smile. Give yourself the best smile. Open your camera, please. Okay. Oke. Udah? Slide kedua. Smile again. Yeah, you can give your best emoticon for the makan Rio. Okay. Slide 3. Finish. Ayu?
Sudah, nurse.
Okay. Finish all?
Belum.
Evidence that everybody attend
Yeah.
the webinar.
Dokter Lili, izin materi boleh
Ya,
dibagikan,
nanti saya
dokter?
tanyakan. Nanti saya
Iya,
tanyakan.
baik. Banyak yang bertanya. Terima kasih.
Ya, terima kasih. Nova, kalau mau tutup silahkan.
Oke. Finish. Oke.
Nurse.
Udah finish.
Ya.
Ya. Oke, Makiko and Rio, we would to like
Terima
to
kasih, Dokter Lili.
yeah.
Ya, terima kasih.
Thank you so much. Terima kasih.
Thank you, Makiko.
Terima kasih.
Oke, we
Thank
close
you.
the Oke, baik teman-teman peserta sekalian, jangan lupa mengingatkan kembali pretest maksimal sampai jam 14, jangan tidak diisi pretestnya karena nanti tidak bisa melanjutkan pembelajaran di pelataran sehat. Baik, dengan berakhirnya seluruh rangkaian acara pada hari ini, sebelum kami tutup, kami akan menampilkan event-event dari Neonatal Education and Training yang akan kami laksanakan di bulan-bulan berikutnya. Yang terdekat, yang pertama akan ada webinar terkait dengan infection control. Bisa di-share videonya. yang pertama di 21 ini kami akan ada update in neonatal infection, evidence-based practice in infection control measures. Jangan lupa daftar di kegiatan ini terkait dengan infeksi. Oke, di tanggal 16 Agustus 2026 kami akan ada terkait dengan early recognition to clinical deterioration in newborn infant. Oke. In October or December kami akan menyelenggarakan second sentani yang kedua, fokusnya di invasif dan non-invasif ventilation. Silakan, ini workshop 2. Dan di Januari kami akan mengadakan basic PAP. Oke, baik. Sebelum saya tutup, ya, silakan. Tidak terasa kita telah berada di penghujung acara update terbaru webinar series NICU, yaitu seminar internasional. Ya, hari ini kita bersama-sama mendapatkan banyak pembelajaran berharga mengenai praktik terbaik perawatan bayi prematur ekstrem di NICU, termasuk pengalaman dan perkembangan pelayanan neonatal di Jepang. Kami mengucapkan terima kasih yang sebesar-besarnya kepada narasumber, Rio dan Makako, moderator, Dr. Lili Runjan, panitia, dan peserta yang telah berpartisipasi aktif dalam menyukseskan kegiatan ini. Semoga ilmu dan pengalaman yang diberikan dapat menjadi inspirasi serta meningkatkan kualitas pelayanan neonatal di tempat kerja kita masing-masing. Saya selaku Master of Ceremony, mohon maaf apabila terdapat kekurangan dalam memandu acara. Sampai jumpa pada webinar dan workshop Neonatal Education and Training berikutnya. Tetap semangat memberikan pelayanan terbaik bagi neonatus dan keluarga. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Terima kasih Dr. Lili, terima kasih semua peserta yang sudah join.
Terima kasih Dr. Lili.
Ya, sama-sama. Kasih.
Terima kasih Dr. Lili. Sehat selalu.
Asistennya ada
Hubungin Nova.
yang hubungin Nova. Dia udah punya asistennya, udah punya nomor Nova.
Belum. Waktu itu dia ngubungin siapa ya? Ane, waktu itu Ane.